So now let's get into the inflammatory aspects of different hair loss conditions. The study's titled The Inflammatory Aspect of Male and Female Pattern Hair Loss by Nadia Paravian et al. And Fibrosing Alopecia in a Pattern Distribution, Patterned Lichen Planopilaris or Androgenetic Alopecia with a Lichenoid Tissue Reaction Pattern by Martin S. Zinkernagel et al. Offer deep insights into the inflammatory mechanisms underlying different types of hair loss. In the study by Nadia Paravian and her colleagues titled The Inflammatory Aspect of Male and Female Pattern Hair Loss, the authors examined the role of inflammation in male and female pattern hair loss. These types of hair loss affect millions of people and are commonly known as male pattern baldness and female pattern baldness. Traditionally, these conditions are attributed to the miniaturization of hair follicles and alterations in the hair growth cycle. However, Paravian and her team present compelling evidence that inflammation is also a significant factor in these conditions. They document the presence of inflammatory cells, such as lymphocytes and histiocytes, around the hair follicles in affected individuals. Additionally, they highlight the involvement of inflammatory genes, including Casp7 and TNF. The study suggests that addressing the inflammatory aspect of male and female pattern hair loss could lead to more effective treatments, as current options like minoxidil and finasteride offer only partial regrowth and limited efficacy. On the other hand, Martin S. Zinkernagel and his co-author Ralph M. Trube, in their study Fibrosing Alopecia in a Pattern Distribution, Patterned Lichen Planopilaris or Androgenetic Alopecia with a Lichenoid Tissue Reaction Pattern, focus on a subset of patients with a scarring form of hair loss. This condition observed in 19 patients. The breakdown between genders was 15 women and 4 men, all featuring progressive hair loss in a pattern similar to androgenetic alopecia, but with significant inflammatory and fibrotic characteristics. The study reveals that these patients display both the miniaturization of hair follicles typical of androgenetic alopecia and the inflammatory feature seen in lichen planopilaris. The authors describe how these patients exhibit symptoms like parafollicular erythema, follicular keratosis, and a loss of follicular openings confined to the areas affected by hair loss. Histologically, the early stages of this condition show a lichenoid inflammatory infiltrate around the upper regions of hair follicles, while advanced stages involve extensive fibrosis and destruction of follicles, similar to lichen planopilaris and pseudopelade of Brock. Comparing the two studies, both emphasize the critical role of inflammation in hair loss, but from different perspectives. The study by Paravian et al. Focuses on non-scarring forms of hair loss, specifically male and female pattern hair loss, and suggests that inflammation contributes significantly to their pathogenesis. They propose that future treatments should address this inflammatory component to enhance efficacy. Conversely, the study by Zinkernagel et al. Explores a condition that intersects between non-scarring and scarring hair loss, showing that some patients with androgenetic alopecia also present with inflammatory and fibrotic changes characteristic of scarring conditions like lichen planopilaris. This study underlines the importance of distinguishing this form of scarring alopecia from traditional androgenetic alopecia for better management and therapeutic strategies. Given the observed potential effects of KPV and its anti-inflammatory properties, it could be used to treat conditions like lichen planopilaris and the inflammatory aspects of androgenetic alopecia that affect not only the hair follicle, but also the sebaceous glands. When I consider conditions like lichen planopilaris and other rare inflammatory skin conditions and diseases, there are limited treatment options available. Aside from corticosteroids and immunosuppressants, painkillers are often used when there is pain. It's truly unfortunate because many people suffer from these conditions. I discussed this in my recent podcast with Dr. William Rassman, the inventor of the follicular unit extraction hair transplant procedure. He mentioned that some of his colleagues have started to routinely biopsy patients before performing hair transplants. This practice is due to the fact that in the past, patients with lichen planopilaris would often experience transplant failures. These issues are more common than we realize, and could explain why some individuals do not respond well to treatments like finasteride, dutasteride, or minoxidil. Their problems may also involve an autoimmune inflammatory condition that attacks the hair follicle and sebaceous glands. Here is a snippet of that interview. Like alopecia areata incognita that can manifest a DUPA-like condition aside from androgenetic alopecia. That being said, have you ever recommended scalp biopsies in your practice when it comes to more atypical patterns of hair loss?
Yes, Dr. Robert Bernstein and Dr. Christine Shaver in New York. Dr. Shaver she's a dermatologist, and she had a particular interest in something called lichen planopilaris, which is another disease of the scalp that causes hair loss. There are a series of diseases of the scalp that cause hair loss, and you don't want to do surgery, hair transplant on people that have fronting fibrosing alopecia or lichen planopilaris or a variety of these other scarring alopecias. So she has made a habit of starting to biopsy young men in two places when she has even a suspicion that there might be some underlying disease, even though it doesn't show very well. And she has found an enormous number of patients have lichen planopilaris, which means that these people, if they had a hair transplant, will fail. Eventually, sooner or later, will lose their hair. So when we look at, I look at my career now 34 years in the hair transplant business, and I used to see every once in a while a patient would come in 10 years out, 7 years out. I even remember somebody 3 years out that came to me and he had a beautiful head of hair after the surgery. And then all of a sudden the hair started to fall out. And I always used to think of the hair around the side and back as permanent. It never went away. But at that time, I didn't understand that these people probably had lichen planopilaris and had this autoimmune disease in the scalp. And it was just inactive. And then as they got older, it became active. We find these diseases far more common in women than men. And for that reason, because they're so common in women, the doctors haven't thought of this as a male disease. And yet it is a male disease. And Dr. Shaver is basically writing this up now for publication. So I think that this is an important observation. And so to answer the question, you make that diagnosis.
I see.
I think if I'm suspicious of something, I'll biopsy it.
From what I see on websites like Reddit, people often suspect that they may not only have androgenic alopecia. And because not everyone is getting a biopsy, it could be the case that issues like lichen planopilaris and other conditions are often overlooked.
The problem in the hair transplant industry, and I don't mean to be too accusatory, but there are many doctors that enter this business that just learn how to do FUE and they don't learn dermatology of the scalp. And if they don't learn dermatology of the scalp and the diseases of the scalp, then they're going to not recognize these diseases, and then they're going to transplant these people as they develop balding, and then they're going to fail maybe 3 or 5 years later.
Yeah.
And when they failed in my hands down the road, and this, by the way, in my practice, the numbers that would fail were about 3% that would fail out there in 5, 10, 15 years later. But I'm sure that those 3% were lichen planopilaris, and a diagnosis that was never made. And by the way, nobody knew about it then. It wasn't like I was just a bad doctor. Nobody had talked about it. It was never considered a disease in men. And sure as hell it is.
Now, in my opinion, there simply isn't enough evidence to suggest that KPV could be used to increase hair growth in humans. However, once again, it doesn't mean it is useless, especially when it comes to scalp inflammation. It may have other uses outside of hair growth. We need to keep this in mind, and hopefully its utility may be appropriately assessed in the future.